So it's a pleasure being here, and basically what I'm going to be presenting is a arthroplasty device for the lumbar spine that just got FDA approved as of June of last year. So, and as at this point right now, I think there are a couple of other surgeons that are trained in Utah. I think I'm the only one that's implanted the device in the U.S. In Utah itself. And so it's designed for treatment of spondylolisthesis. And, and this is the device. This is the older version. And it wasn't until I was helping teach a course that I realized that there was an evolution in the device. There was this Premium TOPS device was first developed in the United States, and then eventually then got migrated to Israel. And through this company Premium in Israel, this is how the FDA approval came about. And so a number of my patients would come in the office if they have a spondylolisthesis and stenosis. And the question is always, well, can't you reconstruct this? Do I have to have a fusion? Because sometimes, there's this negative feeling about having a fusion procedure. So this is a device that allows for decompression of the spine, replacement of the facet joints, and allowing motion in the spine by having this premium. Is it? I think it's my glasses. I thought it was out of, yeah. And it's placed into the spine like this between pedicle screws, but instead of joining the top and the bottom together, this is basically joining from side to side with an articulating joint in between. So the system looks like this, and there's varying degrees of sizes to accommodate the patient's anatomy. Small, medium, and large is basically the width, depending on where you place the pedicle screws. And then there's a distance between the pedicle screws from top to bottom, so then there's these degrees of 21 degrees, 30 degrees, and 38 degrees to accommodate the different versions. And then there are a variety of pedicle screws. If the other surgeons were here, it starts at 5.5, so we can't use smaller screws, 6.5 and 7.5. And most of the fusions we do are in the 6.5 and 7.5 diameter size. And these are the screws that are utilized. And so they have a texture to them, so they've been treated in a way where there can be bone ingrowth. And again, instead of joining from one bone to the next below, this is just joining across and providing the support for the artificial joint. These are instrument sets. It's nice that there's only one set of instruments that you need for this whole procedure. And this is what the device looks like. So there's arms that connect to the pedicle screws at the upper level, lower level, and then this is the joint itself, which has a polyurethane boot around it. So the joint itself you can't see on the picture, but it allows a certain degree of flexion, extension, axial rotation. And once it's in place, and actually what I should do is pass this around. And they put this in a model that you can kind of rip things apart, but if you just move where the screws are, you can see what type of motion you can get with that. And so it's made for, so the indications are for spondylolisthesis up to grade 1 with associated stenosis and symptoms of radiculopathy or claudication pain. Originally, I think the study was for L2 to L5. That was when it started in the United States. Out of Israel, it's now L3 to L5. That said, like a lot of things that are FDA approved, I have patients who I put this in at L2, 3, and at higher levels. So in the study that got approved last year, the indications are very simple. Having the spondylolisthesis, age range between 35 to 80, and so that's fairly straightforward. And like with any FDA study, the contraindications are much larger, so there's a whole bunch of different things that they had to keep track of. And so lytic spondylolisthesis was left out of that, because you would think that if you had a lytic defect, that would be a perfect case for this type of procedure. But when you're trying to work with the FDA, you're trying to, having too many different options and different variations, creates issues in terms of the quality of the data and getting the FDA approval. So currently, lytic spondylolisthesis I would treat, but a majority of those would be at the L5-S1 level, and this device doesn't really fit within L5-S1. So again, it's from upper lumbar down to L5. L5-S1 is really, there's no solution because of the lordotic curve there, but allows this kind of motion. Let's see, T-scores need to be paid attention to, so anything less than -2 can be an issue because you're putting in screws that are now going to be resisting motion and connected to an articulating device. There was an issue regarding scoliosis, that anything greater than 10 degrees, which is not very much. What we're now discussing is whether that could be just segmental, because if you said over L1 to L5, there's a 10-degree scoliosis, and that's an exclusion. That's not allowing very much variability. So the pivotal study was dependent on a number of different things, and there were 208 TOPS procedures, and 94 of the patients had a PLIF procedure. And what they were looking at this primary endpoints were oswestry disability scores, whether there was any neurologic deficits, reoperation rates, opioid usage, other pain medications that were utilized. And so again, during the initial phase, it was 2 to L5, but at the conclusion, it's L3 to L5, but can be expanded to those upper levels. And exclusion criteria, again, patients that are morbidly obese, you wouldn't include in that. If there's more than one level involved, it could be an issue because there's not a solution for using this kind of device at multiple adjacent levels. There isn't a solution for doing a fusion at an adjacent level, and I'll show you an example of that. So this is the demographics of the patients that were in the study. Age was in that 60s age range. Let's see, BMI 30, 29, equal distribution really between male and female, and let's see, predominantly at the L4-5 level, which you would expect, where we see the most of the degenerative spondylolisthesis, and occasionally some lytic spondylolisthesis. And then the operating times are there. So this is the results of that FDA study, and the composite is over here. So the difference between the top group and the percentage achieving success was 77%, looking at all these different type of parameters, as compared to fusion group that was down to 24%. So there's significant difference. And again, this is the inclusion criteria: single level pathology between L3 to L5, moderate spinal stenosis, degenerative spondylolisthesis up to grade 1, and a minimum of 4 millimeter disc height at the index level. And the reason for that is you have to have a certain amount of disc height to actually have useful movement. So if you have a collapsed disc space, trying to put in this device and hoping that it's going to have useful motion, it's kind of a pipe dream, basically. So leg and back pain, predominantly leg symptoms that were in the study. Currently, if you have patients with claudication back pain alone, they would still be a good candidate for this type of procedure. And so in this cascade of things, so if you said disc degeneration from a normal disc down to one that's collapsed and narrowed, it's in between in those between those areas. Same thing with the facet degeneration, that it can be mild versus severe, and in both of those cases, with severe facet, severe disc loss, and facet degeneration, those are not the best patients for this type of procedure. It's in between. So you have some moderate disc degeneration, spinal stenosis, and that would be the ideal kind of candidate. Let's see. Yeah. So patient selection: spondylolisthesis with stenosis. The treatment involves a thorough decompression. So there's complete removal of the facet joints, and that automatically decompresses all aspects of the spinal canal, centrally, laterally, and in the foramen. And then And that's for the surgical teaching, that you avoid any shortcuts and everything like that. So keys would be functional discs at the index level, meaning that there's still active motion. Adjacent levels with only mild degenerative changes. That's changed now that this is FDA approved, because if I have patients that have stenosis at the adjacent level and they're stable, I would consider doing a decompression at that next level. I have a patient that I'm going to show that has a spondylolisthesis at 2 levels. One was appropriate for fusion, the other one was appropriate for the tops, and there is a solution for doing a fusion at the adjacent level. And need to do a wide enough decompression. And then when you're doing the procedure, these pictures here show that the pedicle screws are fairly symmetric, side to side, top to bottom. That's a perfect situation. When we're doing surgery in a live patient, trying to get those all lined up, it's not always so simple. So it's paying a lot of attention and not using any shortcuts. Positioning the patient, they suggested neutral. I actually use a lordotic positioning because I'd like to have the patient to be in that same position with good lordosis. And you do a complete resection of the lamina facet joints, placement of the pedicle screws, that you have to make sure there's adequate space between them, both top to bottom and side to side, and the symmetry. And then we use a type of trajectory where we're putting the screws from lateral to medial, because that provides the greatest strength and resistance to motion that can be generated from that joint. There's a type of instrument that I'll show later that helps to determine what your angles need to be, leveling the screws. And I never use a suction drain, but that's what they recommended in the study. So the interpedicular distance, this distance between the screw heads, needs to be adequate to place that device in. And you can use different angles for placement of the screws. So we usually try and place them parallel to the end plate above, and that usually works well for the spacing. And screw trajectory, if you have this type of arrangement where the screws are not all kind of in the right plane, that's going to be a point of failure for the device. It's already kind of loaded in an asymmetric fashion, so that's what we want to avoid. This is the pendulum, so there's advice once the screw is in place or you have the screwdriver, you can place this, and it has to basically be within this open margin here. That helps get everything put together well. And then there's alignment guides to further determine what the angle size of the implants will be. And then post-approval indications are that junctional disease adjacent to a fusion, you can potentially put in a device. And so my first patient is actually this situation. And I'll show you. It had to, and the key thing was, did I have the screws at the level of the fusion in the right orientation to be able to place this in? If you have post-laminectomy instability, sometimes there's broken facets, equivalent of a spondylolysis, that you can use this type of device to reconstruct the spine and not necessarily do a fusion. And then, let's see, spondylolysis, same thing, that if you have an actual lytic defect. And then if you're doing a TOPS device at one level, so you're reconstructing the joint, can you do a decompression at the level above or below? And that's routinely being done, at least in my series of patients right now. And then this is the extension device, which you can fuse the next one either above or below. You can add a interbody fusion next to the device. And that's what we call a PER, which is a Pro-MIS extension rod. And I have an example of that I'll show you. So with that, let me switch to the other presentation. And
so you were one of the primary of the study, but now is insurance paying for this now in your patient? Or is it still a study phase?
So Medicare is the ideal patient because they can have this device. There's a Medicare, actually, a new technology added payment that the hospitals can receive through that for Medicare patients. All the private insurance is more difficult. And so right now it's at a stage where probably they'll all get rejected. We have to go through an appeal process. And then I've had a few patients who have opted to kind of pay on their own because they'd rather have this type of device rather than a fusion. So it's one of the few times where Medicare is the better way to go at this point right now. So let's see.
I believe that sentence is said.
What's that?
Nothing.
Oh, I see. Yeah. So this is my first patient that I did. And so you usually like to pick some patient that's single level L4-5, just the grade 1 spondy. And that's what you plan for, but then it turns out that this is the first patient that comes up that's available that can do this, and she's very motivated to do this. So a 77-year-old has some medical problems with the hypertension, cholesterol, depression, but functions well at a high level, and had an instrumented fusion that was done at the lowest level, or at L4-5 in 2008, healed, even though there were some broken screws, and then developed problems at the adjacent level at L3-4. So that's when I first met her. So I did an interbody fusion at L3-4, removed the hardware at L4-5, and she did well from that procedure with decompression of the spine and getting rid of her slippage that was present, the spondylolisthesis. And so this is her scans. So she had a fusion down here, and then this is my interbody fusion at 3-4. And at the level above, she's now developed stenosis, and she has a widened facet on the right side, and on dynamic x-rays has some extra motion that's there. And so typically this would be a patient that I would extend the fusion. We'd put in another interbody device. Some people will take out all the hardware. Sometimes we can extend to the next level. But she was hoping that there would be some other options. So this is her x-rays preoperatively. And you can see that whatever was done originally in 2008, those screws broke, but she did develop a stable fusion. This is the fusion I did later, and has an interbody device, and it is healed. And then she has this motion where she corrects an extension, goes forward a little bit in forward flexion, and it's not a lot, but she has claudication pain from a stenosis. Her DEXA score, let's see, upper lumbar T-score, yeah, so it was all greater than the point -1, and her BMI is 34, so she's not thin, but she's not exceedingly heavy. And so the options would be, can I just decompress it again? Or can I do some decompression without a fusion or stabilization? And with a widened facet, there's a risk that that can be a failure point, that there can be a progressive spondylolisthesis. Do you do a direct lateral interbody fusion? You can go from the side and put in an implant with anterior instrumentation or posterior instrumentation. You can do another posterior transforaminal interbody fusion and extend the instrumentation up. That's what typically I would have done in the past. Or could you do some arthroplasty procedures? So this is her current films. And so the hardware at 3-4 was removed. The screw directions were ideal. You can see the ones down here. Now these screws I was planning to remove, but in using a small incision, it was a reach to get those, and I had buried these screw heads down. And once they're locked for a while, you can get the cap out, but it doesn't mean you can get the driver in very easily because the head can be in the wrong orientation. So I decided just to leave those in place. And she's very happy not having additional surgery or a larger incision. And then this is the TOPS device. So the joint is sitting here. And you can see with forward flexion, there's some opening here. With extension, it closes down, so it's moving the way it's supposed to. And at 3 months, she said her VAS was 0. I just saw her, and it is now, let's see, 1 year, and she still puts like a 0 out of 10. Any discomfort she has is more joint-related, like knees, ankles, that type of thing. But in terms of back pain, she really doesn't have any at all. And her Rowland and Morris, which is a disability index, is only 2 out of 24, which is really no significant disability for daily activity. So she's very happy. But yeah, I'd like to say that I wish I could have gotten rid of all the other metal that's down below there. My family. So the second patient is a gentleman was kind of interesting because he saw me out of network. He was in Select Health and was very interested in, knew he had a spondylolisthesis, but didn't want to have a fusion. So he came and saw me out of network toward the end of the year in 23. And then basically, when he could, he switched his insurance to Aetna so that supposedly I could take care of him. So we get him all set up. He has this history of prostate cancer, no prior spine surgery, and has this spondylolisthesis. He's a little on the chunky side with a BMI of 35. And went through like the internet to basically find out about this device, and then went out of network to see me originally, as I said. So his history is that he has slip and fall accident, had a concussion in 2019, and had an epidural steroid injection that helped his right leg pain, but then began developing progressive claudication back pain, as well as pain into the left leg over the past 2 years, and had 6 epidural steroid injections, slowly less and less improvement, and had a medial branch block without any benefit, and is reported that his pain could get up to 8 or 9 out of 10 when he's walking more than a few steps or standing greater than a minute. This is his MRI scan, and doesn't look that bad, but you can see that everything's crowded here at 4-5. And but on his flexion extension views, you can see that he has this corrects in extension and goes forward in flexion, even though he doesn't have widened facet joints. So he had this mobile spondylolisthesis. And so he did undergo surgery. His Aetna created a problem because I normally work out of Lakeview Hospital, and Aetna wouldn't allow him to have surgery there. So because he was had the capability to do things out of, cash pay in a way, we did it at a surgery center. Never done a case this big at the surgery center. Never done this type of case at a surgery center. And so it went like about 5 hours. Anesthesia was pretty good about not getting too upset or anything. We made a deal that he would stay overnight because we had that capability. So the following morning, I come in to do rounds, and my PA is leaving. I said, "Aren't you going to stay? We're going to see him together." He said, "Well, he's not here." So what do you mean he's not here? So he decided after 6 hours that he was feeling good and just checked himself out. And so I'm calling him, and then he sends me this picture with his son at some Minute Mart that he's going, "I'm doing fine." And there was some other picture of him at a Del Taco and all that too. And so then when I see him at 3 weeks, the usual thing after post-op, he says, "I'm feeling really good, and it's been years since I've been on the snowmobile." And it's like, "No, you're not doing anything like this at all." And he goes, "Well, I have this houseboat down at Lake Mead that I have with somebody else, and how about the horses? We have horses down there." I said, "No, you have a Shetland pony or something like that?" And he's like 6'3". He would kill the pony if he was on it. But then, let's see. So 3 weeks post-op, so 0 out of 10 is his VAS. He has 0 out of 24 on his disability. He's doing great. This is his implant. Goes with extension and flexion. There's motion that's there. His kids have seen these pictures. They think he has some drone implanted into his back, with these things. And so at 4 weeks, though, he sends me a video, and this is the video. And let's see. Do you guys have sound on this, or I don't know, maybe not. So basically, he's saying this is how a good trail horse goes down the trail. Oh yeah. So when the horse kind of slides, my wife is looking at this, going, "Oh my God!" And so he's fine from that. And I laugh because he's got a smart dog. He stayed behind and wasn't in front where he'd get crushed and everything like that. And so that's at 1 month he was doing that, and looks fine. And then, and then this is the latest thing. This is like at 7 months.
Fish cleaning station and picnic table and stuff right over in here. This is the trailer I hand loaded last
Yeah,
night.
this is not like, can I do this? It's like,
I
no,
just
you
wanted
can.
to show everybody what a real back can do after back surgery. Did that all by myself. There's another 100 right here. Stacked in here.
So-
Probably more than 100.
Problem will be whether I can reproduce this later on again.
All neatly stacked.
Yeah.
This is great. It's gonna come back tomorrow.
Yeah,
Got in the
yeah.
hot tub, and my back feels great. Don't know if it's going to be after I unload these. I'm going to try to slide them off with the track hoe. Anyway, I don't know how that's going to go, but that's my labor-saving thought.
There was also one in between where he was wakeboarding too. So
Sure.
I didn't put that one up because,
So the
So-
picture you showed
Uh-huh.
prior to these, it still looked like he had some spondylo.
yeah, it doesn't reverse it completely. So depending how you position the patient, you might get some improvement, but basically there's going to still be some spondylolisthesis there, but
Just know where the
with no
spondylo-
facet joints there, there's no potential for compression of the nerves. So
Face cleaning.
Still mobile.
what's that?
Even if the segment's still moving a little bit, you're fine with that.
Yeah, because it is going to move, and it's probably unrealistic for this device to try and cantilever it to eliminate the spondylolisthesis. So it's just moving with the slippage that's there. Yeah.
Is he not having any pain then from the disc, or it looks like there's a little motive, maybe?
Yeah, so those are the things that you kind of worry about at different times. But he's basically pain-free, and I keep on waiting to get some call from him that there's some problem. But it's now getting. Let's say I did his surgery at the end of January, so January would be 1 year, and he's back to all of his activities. He sent me a picture. He was just on some 4-week Yukon horseback riding excursion, and I think I said, "You look thinner." And he says, "Yeah, I've lost about 50 pounds." So, yeah. So he's my star pupil, but one that makes me nervous all the time. Yeah. So, and then this patient is a 70-year-old retired lawyer, has this claudication back and right leg pain, spondylolisthesis with stenosis. I worked together with Scott Adelman, and so we do some cases together, and Scott took care of him and did an endoscopic decompression. Helped a little bit, but didn't really get rid of all the symptoms because he needed more of a decompression. And let's see, and then he develops a new left-sided leg pain beginning of this year. And his pain level was 7 to 8 when standing more than 10 minutes and would go away completely when he was sitting. So this is his MRI scan. And the tight stenosis is at L4-5 here. And you can see the spondylolisthesis there on the sagittal image. And the next level above is narrowed, and he has widened facets there. The next one above that, there's still some spinal fluid that's present there, and that became like the issue, do you do anything or not there? This is his x-rays, so he has a little more than a 10-degree scoliosis and all that there. But at the L3-4 level, again, he flexes forward and there's an anterolisthesis and it corrects with extension. And so in his case, I thought the TOPS would work well for that upper level that was moving. The lower level where there's the stenosis, there's very little motion there. So that I thought could be a fusion level. And because there's a solution for that, that's what we proceeded with.
So how many millimeters is moving there?
It's probably in that range of, what is it? Probably 3 or 4 millimeters.
Isn't that kind of the cutoff of what you consider as like an unstable back, about 4 millimeters?
Yeah. So that's where, when we start seeing that, that was an automatic indication for a fusion. But in this case, this is what he ended up getting. So this is the TOPS device at L3-4. And at L4-5, there's an interbody device here. That's where the bone graft material is sitting there. And then these are extensions that come off from there. And, they were, I think, originally designed like putting the screws from lateral to medial. But this is a different form of type of screw trajectory that's called cortical screws. And by doing that, it minimizes the amount of exposure you have to do. And I can use a smaller incision. So that allowed him to have both levels treated. The upper level, there's some stenosis above that, but it's not something that I addressed, and we'll watch and see. And if he does need some other decompression alone, I can always do that at a later
So
date.
you fuse the bottom level and you tops the other level.
Yes, yeah. So, and that's my plug. My adopted rescue dog, and then one of the twins that my son has. So. Any questions about all that? Yeah.
What about the contraindications? You said one was beyond a grade 1.
Mhm.
Is that just like you're saying because the device itself won't hold it from moving that far?
Yeah, I don't think there's a good solution for anything more than a grade 1, and that would necessitate I mean, a fusion at that level. Yeah.
And then also with the inner body devices,
Mhm.
kind of raising up those classic discs, would it not be possible to put one in with the TOPS device if you had a really
You mean
narrow disc?
in
I mean, because you were saying one of the contraindications, you wouldn't put the TOPS device where you've got no
Yeah.
disc left.
I guess the way I tell the patients is that as the degeneration progresses, you can get to a stage where there's very little motion. And talking about an artificial disc or this type of arthroplasty device, I tell the patient it's not the fountain of youth. It's not going to reverse everything. So there has to be, it's preserving the motion that's there naturally. And sometimes it could be a little augmented, but in that one case where it's collapsed that way, I didn't think that was an indication for this type of arthroplasty.
How big of an incision are we looking at?
Well, I've been working through smaller incisions, and when the premium people come in to help support the case, they're always telling me to make the incision bigger because I'm fighting through all that. But at the same token, I want to minimize the amount of destruction and injury to the paraspinal muscles. There's all this discussion about sarcopenia and what happens when we do spine surgery. So you'd like to preserve the muscles as much as possible. So I think I'm one of maybe one or two people where we're putting screws in through separate stab wounds and then hooking everything up centrally through a smaller incision. And so like tomorrow I'm flying out for a course out in New York, and part of it is to kind of look at the instrumentation there and see what we can do to kind of modify it to make it more user-friendly for a small incision. It's a lot of retraction. If you back up to like this, these screw positions out here, let's see, here and here, it requires a lot of muscle retraction to get those in well. And so if you put them in through stab wounds and use a less invasive technique, you can get them in, minimize the incision below, but it's just fighting to get all that hooked up afterwards. Yeah. So, yeah. But let's see, I did, what's that? Oh, I was just going to say, and I did my sixth case, it's just got FDA approved in June of 23. The first case I got to do was in October of 23 by the time everything filters through the hospital systems. And the case I just did 2 weeks ago, that was one where there was a spondylolisthesis that was stable below. And so I decompressed that just by using a small laminotomy, what we call an interlaminar decompression. The level above had small facet joints and had some extra motion, so I did a TOPS at that level. So that's where combining, the arthroplasty at one level and being able to decompress the spinal canal at another, those are things that are now possible that weren't part of the original FDA study. You were asking though?
When you snip the facet, does
Uh-huh.
it sometimes just give? I mean,
No, you have to, it's a process well, the way I do it is I remove the spinous process, and so there's that cancellous bone in the middle. I'll take a high-speed drill and we'll drill that down until you get the inner layer there. And then at that point, then you go laterally out below the pedicles above at the pars region. And so basically creating a surgical pars defect on both sides. So then you just remove that. And then you have to remove a part of the supraarticular process coming from below. And just have to, physically look and make sure that there's nothing that's going to cause, the concern is that as you allow motion there, will you leave anything behind that could impinge on the nerve? So there is a pretty generous decompression you have to do. But it is, any operation we do, there can be multiple points of no return. And once the facet's out there, it's like, well, this has all got to go together well, because otherwise, I have to do. We always have a backup for a fusion if we should need that. But yeah, so far we haven't had to do that in any case. So yeah.
Oh, so like, wait a second.
Well, that's the little box in the corner of the room. Yeah.
Okay.
Yeah.
So you just said L2 or L3 to S1?
Well, the FDA approval is for L3 to 5,
Oh,
3, 4, 4, 5, because that's what they limited it to. So far, there hasn't been any, because I'm doing Medicare and we don't need to get pre-approval. I've done them at 2, 3, and there's another patient that could be for L1, 2. So it all depends on their anatomy and whether that would fit.
Are they trying to work on higher up?
For the thoracic, there isn't any reason to do that, though. There's not enough motion there. So it's really just the lumbar spine. And it'd be nice if there was some solution for L5S1, but right now it's because of the lordosis and the size of the disc there, the posterior area that just doesn't have enough space to put something in like that. You'd have to create some new device that would fit in that area.
Same with cervical, because that has a lot of movement.
Yeah, that would be a different anatomy completely. The facet orientation is different. Yeah.
Okay,
Yeah.
that's true.
Yeah.
Wow, thank you. That's very
Okay.
cool.
All right.
One other question.
Mhm.
Why do you think the results were so much better than the fusion? I mean, they're both decompressed.
Yeah.
Fusion,
Part of it would be whether the fusion rates were adequate. So that's one aspect. And I'm not sure, since I wasn't part of the study, I'm not sure exactly what the primary fusion technique was being used. And then the other is the decompression is much bigger putting in this arthroplasty device than with an interbody fusion. There we're still trying to preserve some of the bone structure because all of that can contribute to like the healing and development of a fusion between, say, L4 and L5. And then let's say if there was any failure of the fusion, there was other procedures. And so when you add all those things together, it was that there was just a big difference between the fusion group and the TOPS device.
Another compare and contrast with the TOPS device and the fusion. I believe you already touched on this, but I missed it. Because there's some mobility allowed with the TOPS device, does it prevent the degeneration of the segment above, segment below that you get with the fusion?
Well, that's the holy grail. That's what we all believe can happen. And so even with artificial cervical discs, can you leave a level that you might be worried about with a fusion alone because you have an arthroplasty device right next to it? And so I believe that. And in this one patient that I had, I avoided treating the next level above just because of the length of the surgery and what was needed, and I didn't believe it was contributing to his symptoms. But that's where, by having that device in and promoting some normal motion there, hopefully you're preventing some of the accelerated degeneration of the adjacent levels.
It's too early to tell for those studies, right?
Yeah, the cervical spine, I think that's starting to show up now. But it's when you do 2 or 3 level artificial discs, and the discs are all designed or FDA approved for 2 levels, but there are people that have had 3 level arthroplasties done. And so as you get to the greater numbers, the difference between that and a fusion it becomes very dramatic, and the effect that it can have on the adjacent level should be a very positive thing with an arthroplasty as compared to doing a fusion.
Thank you.
Okay.
That was
Yeah.
awesome. Easy, guys. Easy.